Hello and welcome, everyone. My name is Tess Taylor, and I'm a specialist in the Community Education Department at MDA. We're excited to have you join us for today's webinar, Cardiac Care for Becker Muscular Dystrophy. Following the webinar, please stick around to hear a presentation from the patient engagement team at Edgewise Therapeutics. They will be providing information on resources they offer for BMD patients. This learning event is part of our larger MDA community education program, which focuses on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates on upcoming events, and stick around to the end of the webinar for more specifics on our programming. We are recording today's event and will be posting it to the website for on-demand viewing at a later date. If you're joining us live, please note that all phone lines have been muted, but we are looking forward to your questions today. We'll have a Q&A session at the end of the webinar with today's presenter. Feel free to type your questions using the chat feature as you think of them, and we'll get to as many general questions as we can after the presentation. MDA would like to thank our sponsor, Edgewise Therapeutics, for partnering with us to bring you today's webinar. For nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. Now it is my pleasure to introduce today's speaker, Rabia Khan, MD. Dr. Khan is a clinical assistant professor and transplant cardiologist in the Division of Cardiology at the University of Iowa Healthcare. She also serves as the Associate Program Director for the Pediatric Residency Program in the Department of Pediatrics. Dr. Khan is dedicated to advancing the care of pediatric patients with cardiovascular conditions, with a special focus on transplant cardiology. Hi, Dr. Khan. Thank you so much for being here today. I will now turn the time over to you. We're looking forward to your presentation.
Thank you so much for that wonderful introduction. Let's see if I can share here. All right. Are you able to see everything okay?
That looks great. Thank you so much.
All right, wonderful. Thank you so much for having me. I'm very excited about this talk. As Tess mentioned, I'm a transplant cardiologist, and I follow a lot of patients with cardiomyopathy. Neuromuscular disease has actually been an interest of mine since my training. I did my advanced training in Cincinnati, and there was a large population of patients with muscular dystrophy that were seen there, and that's where my interest initially started. It's a rapidly developing field. There's a lot that I don't know right now about it, but I'm going to do my best to present what I have learned throughout my training and in these first several years of my career. All right, so we'll start by discussing some of the cardiac implications of Becker muscular dystrophy. Sorry, let me move this out of the way. All right. Why it's important to think of the heart. And then we'll outline how we monitor and screen for cardiac conditions. I'll describe some of the current cardiac therapies and what specifically they target. And then I'll summarize some of the newer developments, the recent research that's aimed at developing a better understanding of Becker muscular dystrophy and some targeted therapies as well. All right, so just as a brief introduction, and I won't belabor this too much because I know that most people probably already have a general understanding of the disease, but Becker muscular dystrophy belongs to a group of dystrophinopathies, also includes Duchenne muscular dystrophy, named for a German doctor, Peter Emil Becker, who described it first in the 1950s. And the issue here is that the dystrophin gene on the X chromosome is affected, and you have, in Becker, you have a partially functional protein. And this protein actually serves as kind of a connection between the actin cytoskeleton within the muscle cell to sort of the outside of the cell. So there's this complex, and dystrophin forms a big part of that. And without a functional protein, it really limits kind of muscle function over time. So for Becker, the onset tends to be around kind of the late childhood and teenage years, as opposed to in Duchenne, where they tend to present a little bit earlier in childhood, just because the presentation tends to be a little bit less severe. The As far as the epidemiology, the frequency is about 1.6 per 100,000 cases in the US, about 1/10 of the frequency. I read a little bit of different things, 1/6 in some places, 1/10, but definitely less than the frequency that we see DMD. There's several different organ systems that are involved. So the skeletal muscle is the primary. That's kind of where the diagnosis is usually made. So progressive weakness, myalgias, cramps. Bones can be impacted with osteopenia. In some patients, you can have some neuropsychiatric problems such as learning disabilities, autism, rarely epilepsy as well. And then the cardiac, which we'll focus on now, will be the cardiomyopathy. And then associated with that, there can be arrhythmias as well, so heart rhythm issues. So now we'll get right into the cardiac involvement. So there will be many patients with the diagnosis who won't have any cardiac involvement and may be asymptomatic even throughout their lives, or for a vast majority of their lives. About one third will develop kind of early dilated cardiomyopathy. And so what that means is that this is kind of what a normal heart looks like here. And if somebody's in front of you, then this would be their right side. So this is the right side, and this is the left side of the heart. And the lower chambers are the pumping chambers that pump blood out. And the left lower chamber, this is the one that pumps blood out to the body. So this is shown as red blood here. So it's oxygenated blood that's pumped out to the body. And the this left ventricle, this chamber, is the one that's most affected by cardiomyopathies in general. And in this one as well. Although you can get a lot of right-sided involvement, but the left-sided involvement is going to be what's really going to drive the symptoms for these patients. So in dilated cardiomyopathy, you can have dilation, so increase in size of that ventricle. And sometimes, as I mentioned, the right can be involved as well. And being more stretched out and thin, it also doesn't squeeze well. So these patients can present with who have the features of dilated cardiomyopathy with heart failure symptoms. You can have arrhythmias secondary to the effects that happen to the heart muscle. And then some of them can have a sudden cardiac death as well, that puts you at risk for that. In Becker, based on some of the literature I read, there can be a higher probability of, or just more likely to have symptoms. And most of that's because these patients will have less skeletal muscle involvement and maybe more active. So they're more likely to feel the symptoms related to their heart dysfunction. So I know this is a very busy slide, and I won't go into too much detail, but what this sort of describes is how having an abnormal dystrophin protein ultimately leads to going down the path of heart failure. So essentially, there's some channels within the muscular cell membrane that are affected, and they're dysfunctional, and the membrane may become more permeable. So things can pass through that membrane, and that leads to entry of excess extracellular calcium, and that ultimately leads to some cardiac muscle death, muscle cell death. And with that, you can have an inflammatory response develop. You can have some scarring tissue. So fibrosis is like scar tissue that forms, and there's areas that become stretched out and thin. And ultimately, this leads to that chamber being enlarged and there being a lot of stress on that chamber, and ultimately to the symptoms that we describe as heart failure. And here's a little bit more about kind of the cardiac physiology and why you develop heart failure. So if there's injury of the heart muscle cells, that causes a decrease in how those cells can contract and work, how that muscle works. And then the heart is just not able to push out as much blood anymore. So the stroke volumes, so every time the heart squeezes, it's less blood that's ejected from the heart. And there's high pressures in the heart that lead to a lot of the congestion type symptoms that people can get from heart failure. So lung congestion, trouble, difficulty breathing with activity, maybe needing to use a lot of pillows when sleeping and having fluid in their lungs. And then the systemic, which meaning in the body, they can have some swollen, or not swelling exactly, but they could have their vessels in their neck be very apparent. That's the JVD. Their liver can be enlarged because of extra congestion, and they can develop fluid in their body as well. And then with the dilation of that left ventricle, the valve that sits right above the left ventricle, that whole valve apparatus where it's sitting also becomes dilated, and that leads to leaking of that valve. And then you have less heart output, and that leads to some of the symptoms of fatigue and weakness. So this sort of describes why having this injury to your heart can lead ultimately to all these different symptoms. And then there's some other things that happen as the body is trying to make things better that might be good in the acute setting. So if somebody comes in with terrible heart failure acutely, then some of these things can be beneficial to increase their blood pressure and allow them to have blood flow to organs. But in the long term, some of these changes that the body is kind of undertaking are actually going to cause more harm. So when the body notices that the blood pressure is a little bit low, it activates what we call a sympathetic nervous system and releases some hormones. Norepinephrine is one of them that can increase the blood pressure in the short term and be beneficial, but in the long term, that is going to increase the demand of oxygen by the heart muscle and cause some secondary injury to the heart muscle. So that's what myocardium is, the heart muscle. And then on the other side, if somebody has heart failure and their kidneys are not seeing a lot of blood flow, that causes the body to activate this hormonal system here. And the goal of that is to retain more fluid. But that also can lead to the heart having to work hard and to have some secondary injury. So there's a primary injury, and then the response to that primary injury is actually what leads to some of the secondary injury that happens. Sorry. So some of the diagnostic tools that we use, I'll go into that, but at first I'll talk a little bit about kind of the screening protocol. So this is something that I found for both DMD and BMD. So in DMD, it's a little bit closer follow-up. So even if in someone who doesn't have any cardiac features, once they have a diagnosis, they usually recommend an EKG, and also this a TTE is an echocardiogram. So an echocardiogram every 2 years until age 10, and then at least once a year. And then if they actually have symptoms, then we do it more frequently. But in Becker, usually the likelihood of developing cardiac issues early, I mean, some people might, but are a little bit lower early on. So you start more at every 5 years until you actually see some signs, and then you can increase that. So this is a general guideline to go by. People might be a little bit more cautious and see patients more often, but this is one way that we can follow. And for asymptomatic female carriers, after the age of 16, there is a recommendation to do a screening. So one thing that we do, like I mentioned, EKG, or they're also called ECG, electrocardiogram. With these, we're looking at the heart rhythm. So that's one thing. We're making sure that there's no arrhythmias. But in addition, we're also looking at how the electricity travels through the heart muscle in different directions, and whether there's any abnormalities with how that electricity is traveling through the heart, how that heart is responding to that. So there's a few changes that we can see. So a lot of patients with muscular dystrophy tend to have what we call sinus tachycardia. So it just means that their heart rate tends to be faster than what would normally be expected for their age. So that specifically is not as much of a a problem per se, except that the heart doesn't work quite as efficiently at higher heart rates. So sometimes if it's really fast, we do want to slow it down. So that's something we look at on EKG, but we can also do a longer monitor to kind of assess it over a 1 day period or a multiple day period. So we can do that sometimes. I'm going to skip to this one right here. So these are just certain waves that we see that are prominent. So a Q wave is this downward deflection that we're seeing in lead one here, and we're also seeing it in AVL. So these are not commonly seen in healthy hearts, but this is something that we can see. And there's a lot of other changes here that are listed in how the EKG looks that's different from what we would normally expect. Aside from that, there can be rhythm problems. So the atria are the top two chambers of the heart. So you can have arrhythmias that affect the top two chambers, which I've seen quite frequently. And then ventricular arrhythmias, particularly when you start developing more significant heart dysfunction, patients become at higher risk for arrhythmias from the lower chambers. And these are the ones that are more life-threatening. So these are things that we are looking for and trying to kind of treat early, or maybe even treat before they come about if we're starting to see some tachycardia. And then this is an echocardiogram. So this is a very extreme example of someone with dilated cardiomyopathy. So this is their left ventricle, and as you can see, it's very globular, round, and really not squeezing much, mainly just rocking. This should actually normally be squeezing enough that about 60% of the blood is pushed out. And you can see, I don't even know if this will be 10% here. So this is quite poor function. So these are what we follow. And dilation of these ventricles is common in Becker muscular dystrophy over time. The right is actually more likely to be affected, but there's less consequence of that. And then the left will be affected in about 35% of patients, and about 29% will develop a decreased ejection fraction. That's the squeeze that I was describing. So what fraction of blood is pushed out. And then in some patients, you'll see what we call wall motion abnormalities before they actually develop dysfunction. So the total amount of blood pushed out of the heart might be normal, but there'll be areas that don't move as well as others. And the inferolateral wall, that's an area right over here that tends to be more vulnerable. We've been using cardiac MRI a lot more, particularly in Duchenne muscular dystrophy, but also in Becker, and also with following the carriers and making sure that they're not at risk for developing cardiomyopathy. And the main reason that we are using cardiac MRIs more often is because they will show signs even before you see signs on echocardiogram. So some of the things that you start seeing is going to be subepicardial fibrosis. So right under here, let me just explain what we're seeing here. So this is it's kind of on its side, but this is the wall of that left ventricle. And this is kind of the inside where the blood is. So this is that kind of side wall over here. And within that wall, kind of right under what we call the epicardial layer, so that's the outside of the heart, right under there will be this fibrosis or scarring that will happen that we can see with MRI that we would not be able to see with echocardiogram. And we call it late gadolinium enhancement. So there's a contrast called gadolinium that we use. And we see it enhance and it looks something like this. And this can allow kind of early detection. There's also something called global strain, which kind of takes into account how all different parts of the heart muscle are moving. And sometimes you can capture a decline earlier with that than actually looking at the ejection fraction that we use on echocardiogram. This is a different type of imaging modality in cardiac MRI that is actually looking specifically at fat. So in that upper layer of the heart, you can, and it's hard to know what this is actually showing, but this is that left ventricle in cross section. So you're seeing it as a circle. It's like you cut across here, and around there's this fat that's enhancing that's not supposed to be there. So this is something that's can be an early sign too. So when you start seeing these signs, even if the heart function is okay, if you start seeing it early, then that might be a patient that needs a little bit more aggressive therapy. And then labs are a little bit challenging. So troponin In muscular dystrophy, a troponin tends to be elevated at baseline. Um, and so it's really hard to use as a sign of heart injury because it'll be elevated even without any other signs of heart issues. The troponin is something that's released from the heart when it's injured. So what we tend to do is to establish a baseline just to know where people trend. And every few years, at least every few years, maybe even more often, I would recheck and make sure that we know kind of where the troponin trends, so that if somebody were to present to an emergency room complaining of chest pain, and they obtained a troponin and an EKG, we can compare those to what their baseline is and see if it's actually different. Is there any sign of any kind of a more acute injury that's happening right now to the heart? BNP or NT-proBNP, these are kind of variation. One is a variation of the other. These are very helpful for heart failure and most other forms of heart failure, because when the heart is stretched out, it releases this. And so if patients have excess fluid on board and their heart failure is worse, then this number tends to be higher. But there's been studies in muscular dystrophy that have shown that there isn't really as clear of a correlation between lab elevation and having the dilated cardiomyopathy. But there was one study, I think this is this one here down here that I've cited, that did show that if you have severely depressed left ventricular function, then it's more predictable. It's correlating a little more predictably with worsening heart failure. So it can be used in certain patients. Now, as far as the heart management, it sort of depends on how bad the heart condition is. And this is sort of a general guideline that we use for heart failure. Some of it will be a little bit different for muscular dystrophy, and I'll talk about why. But there's the patients who are at risk, and you really are just trying to eliminate the risk factors. And then when they're starting to show some signs, then you start treating them with these medications, ACE inhibitors. You may add on beta blockers, and then there's other medications you add on as the things become more severe. And then kind of later, if none of these things are really working and they have refractory symptoms that are not responding, or very poor quality of life due to heart failure symptoms, then they may require hospitalization for IV medications. And then you have to start thinking about transplantation and ventricular assist devices, which are all things I'm going to cover a little bit in this, a little bit later in this talk. So as far as the outpatient management for these patients, so in heart failure, especially in the adult world, there's something that they call guideline-directed medical therapy. And these tend to be the medications that they try to get everybody started on. And so one is ACE inhibitor. So this kind of targets, and I'm going to go back to the slide where I showed the neurohormonal effects. And the pathway I showed where the kidneys try to retain more fluid, that's the pathway that this targets. So it's a blood pressure medication, but it's also targeting that pathway to try to decrease some of those, what we call maladaptive things that the body is doing in response to the heart failure to try to prevent some of that secondary injury. Beta blockers, same thing. It's a blood pressure medication, but it also targets some of that sympathetic nervous system activation. That was on the other side of that slide that causes some secondary injury as well. So those two are kind of the mainstay, and we tend to start those a little bit early. And then spironolactone, eplerenone. So these are antifibrotic medications. These will decrease the scarring that's happening and slow it down. So this is also something that we want to consider early. Now, in other forms of heart failure, there's SGLT2 inhibitors. That used to be it was a diabetes medication, but was shown to have a lot of benefit in heart failure. We don't really have a lot of muscular dystrophy experience, but I think there's some of that is being started now, and I'll talk about that. But these are kind of medications that we consider some of the first lines. And really, ACE inhibitors are the ones that we really want to start early for these patients who are at risk. Diuretics, so those help get rid of fluids if you need them. Digoxin is another older heart failure medication that has not been shown to really improve survival in the long term or even improve outcomes, but it does help in symptoms. So it does help with symptoms. So in some patients who are on all these medications and are not getting a lot of benefit, sometimes we can consider it. It just you have to make sure you don't go too high on the dose because there are significant toxic effects of that. There's some newer agents. So instead of the ACE inhibitors, or like there's an alternative to ACE inhibitors, ARBs, that also target the same pathway. Entresto is a little bit of a combination med. So you have the ARB effect, but there's something else called a neprilysin inhibitor. And the purpose of that is to keep some hormones around. Actually, BNP is the hormone. So it's what the heart releases when it's under stress. And you want to keep more of that around in order to help the body get rid of excess fluid. So this is a combination medicine that sometimes we use instead of the ACE inhibitors. And nasiratide is also also targets that BNP pathway. Ivabradine is a pacemaker current inhibitor. So what it does is it slows the heart rate down. Beta blockers also do that. They slow down the heart rate. So we usually start with this, but if a patient has a very fast heart rate despite being on good, adequate beta blocker therapy, or if they have a lot of side effects from beta blockers and they just can't tolerate it, this is another medication that can be considered. That's a newer agent. So what are the differences in neuromuscular disease is we really would want to start some of these medications early, even before we see signs of LV dysfunction, because there's been several studies that have shown that that is actually beneficial and that slows down, or actually it delays the onset and it slows down the progression of the left ventricular dysfunction. So these, a couple of these papers are for Duchenne, but there's also a Becker Muscular Dystrophy paper. So perindopril, this is not a common one that we use here, but I think it's used in other countries a lot more. It's an ACE inhibitor. And starting it, and what this study particularly showed, is that starting it early actually kind of slowed down the process. It's a study out of France from 2005. And these patients, when they started it between the age of 9 and 13, they were less likely to develop a decreased ejection fraction by the end of the study, and also less likely to have symptomatic heart disease. Here's another paper that was out of our institution here, and I was involved in this. That's more recent, just from last year. Kind of showed some of the same things that also a Duchenne paper, but shows that starting more than 1 year before you actually start developing left ventricular dysfunction, which of course is not something we can predict. So we just have to start early. So starting these medications will delayed and slowed the left ventricular dysfunction. So sort of some of the same things. And then here's a specific paper for Becker Muscular Dystrophy. So this is from 2021. It's also out of France, and it shows that despite the fact that the guidelines that they followed from American Heart Association said that you should start when the ejection fraction of the heart drops below 40%, but they started it when the ejection fraction dropped below 50, and they saw a better impact of that. So early treatment is going to be beneficial. Now I'm going to talk a little bit about the electrical system and kind of how we can address that as well. So patients with muscular dystrophy are at risk of arrhythmia. So heart rhythm abnormalities, very fast heartbeats that can make people very sick, and can also kind of prevent the effective work of the heart. So early initiation of the beta blocker can help slow the heart rate, and can help with prevent these arrhythmias. And then there's other medications can also be added on if you're really seeing a lot of arrhythmia. So definitely we can do the pharmacologic management with medications. But sometimes these arrhythmias are actually coming from a specific place, and you can actually get rid of that electrical pathway through a catheter ablation. So go to the cath lab. It's kind of a semi-invasive procedure, but you drive a catheter into the heart and find the location and just do a radio frequency ablation and get rid of it. And then there's been, some good success. I only found a couple of case reports, but they seem to suggest that this is definitely um, something that can be considered. So here's one of these case reports. So this is back from quite a while ago, 1998. There was an arrhythmia that came from a specific area in the ventricles, the lower chambers of the heart, and they used a radiofrequency catheter to eliminate that pathway completely. And after that, this patient had no further arrhythmias. So it worked pretty well. And then here's another one. So Wolff-Parkinson-White is a specific extra electrical pathway that we see in cardiology quite frequently in children and in adults. And in this patient, that was actually the first sign. So arrhythmias, because of this extra electrical pathway, was the first sign that something was wrong with their heart. And then later they started developing the muscle weakness that allowed them to be diagnosed with the Becker muscular dystrophy. And so this patient went for catheter ablation, but interestingly, this pathway, I think, self-resolved and they didn't need it. But again, a patient where it was considered, and if they would have gone, if the pathway would have been there, I would expect it would be successful based on kind of my experience with the Wolff-Parkinson-White pathway. So it's something that can be an option. And then in some patients who have heart dysfunction, pacing both ventricles, so putting a pacemaker that paces both of them and actually synchronizes them better, because sometimes you get out of sync where one ventricle is squeezing and at one time and the other one has a delay. It's called a bundle branch block. So there's a little block in the electrical pathway going to that heart that leads it to squeeze a little bit later. And sometimes if you get those in sync, you can actually improve the heart function. And this is something that we often consider with some of our patients who have bundle branch block and have heart dysfunction. And so this has been successfully done in Becker muscular dystrophy as well. So this is a case report from 2013 in a 44-year-old where they paced both lower chambers, and that synchronization led to an improvement in the function of the left ventricle. There was less valve leakage because of this, and also the symptoms improved as well. So this was a good outcome from this. I'll go back for a second. ICD placement. So an ICD is an implantable defibrillator. So if patients are at risk for sudden death, sometimes we advise placing a defibrillator so that if they were to have an arrhythmia that could be life-threatening, this device would shock them out of it. Sorry. There we go. Per adult guidelines, anyone with an ejection fraction less than 35 on maximal medical therapy should be considered for an ICD. In pediatrics, the guidelines are not as clear, but in very high-risk patients, it's something that can be considered. Of course, in muscular dystrophy, we have to kind of weigh risk and benefit with going on under anesthesia and placing a device. But in certain patients who are at high risk, it may be the right thing to do in order to prevent a sudden death event. Sorry, let's go. I think that's where I am. Yes. Okay, now let's talk a little bit about some of the new developments and some of the things that I'm excited about in terms of the future of therapy and muscular dystrophy, and also kind of monitoring and all of these things. So Action Network. So I became particularly involved in Action Network because it is a group that started at Cincinnati Children's Hospital, and that's where as I mentioned, I did my advanced fellowship. And so I got to know about it pretty deeply when I was there. It's a great organization. They're working towards a lot, improving care in heart failure in general. And there is a section on muscular dystrophy. And, even though this specifically is talking about DMD, I think that a lot of what it says in here can be used for Becker muscular dystrophy as well. So this is a specific harmonized protocol that they came up with. So by harmonized, they meant is trying to get different centers to kind of do what is evidence-based instead of everyone sort of doing their own thing. And provide sort of some guidelines as to how we could start medications and how we can titrate them for heart disease in this population. So here's an example. So this is for ACE inhibitors. So there's these 3 different ACE inhibitors, and they give some guidelines on what initial dose to start. and how to start it and what's the target dose prior to developing any signs of heart failure. And then when they have signs of heart dysfunction, then what do you want to target at that time? And how much do you want to increase by safely? So these are, and then this is for the kind of alternative, the ARB therapies that are also kind of the same class. So this is these are some helpful guidelines, and I generally tend to follow them, but of course, every patient is going to be a little bit different. Their side effects will be different. So we may have to adjust it, but it's good to have something that is evidence-based that has worked well for a lot of institutions. So I really like some of the work that Action is doing. There's a lot of other things that they're working on. But this is something that I think is very helpful, just day-to-day management. I talked a little bit about SGLT2 inhibitors, and I'll remind you what that was. So when I talked about the guideline-directed therapies that are being used for adults for heart failure, most of them are using quadruple therapy. So the ACE inhibitor, the beta blocker, and then the spironolactone, and then this is the fourth one. This is the one that used to be a diabetes drug, but has shown a lot of promise in heart failure. So the issue is that right now we just don't know in Duchenne muscular dystrophy and Becker muscular dystrophy if this is going to be the right treatment. Is it going to be helpful as it is in other patients? But because of the promise it's shown in other patients, we really, I'm excited about kind of seeing where it goes. So this is an initial study that was done from, this is a poster presentation that was done last year. And I hope that there will be something in publication where there were 24 patients prescribed an SGLT2 inhibitor, and 2 had to stop it early because they had symptoms from it, so low blood pressure and dizziness, and they ended up not continuing with the study. I wonder if maybe a lower dose would have helped, but I think for the guidelines that they had in the study, they didn't want to approach that. So what I think this says, because the rest of them were able to continue it through the course of the study, that we have demonstrated that most patients will be safe using it. But I think we need more research. We need more studies to demonstrate how effective this is going to be. I do think there may be some centers that are starting to use it in muscular dystrophy, but I think that there's just not a lot of evidence behind it yet. So we have to make sure that we're doing the right thing. Okay, ventricular assist devices and heart transplant. So this is really an exciting area where I think that there's a lot of potential. I think as we're keeping other organ systems healthier for patients with muscular dystrophy, the heart is going to be the big one to focus on. And in patients who have significant heart dysfunction, there may be a subset of patients, particularly actually patients with Becker muscular dystrophy, who may not have as many other organs impacted and may have kind of a long life ahead of them if we take care of their heart, and maybe good candidates for some of these therapies. So I'm going to talk initially about ventricular assist device, and then we'll go over to transplant. So there have been various cases worldwide of successful use of ventricular assist device for muscular dystrophy as a bridge to transplant. So getting patients to transplant as a bridge to making a decision whether they can be a transplant candidate, or something called destination therapy, where we don't really want to move towards transplant because of various reasons. There's maybe too much risk. And so this device could be there for many, many years, and patients can just live on this device. So what this device is, it's basically a pump that assists the function of the heart. So here is the left ventricle here, and you have to make kind of a hole in it where then you're kind of pulling the blood in. There's a motor here, and then the blood is being delivered to the big vessel of the body, the aorta, so that it can supply it everywhere in the blood, in the body. So this is what it looks like. All of this actually lives inside the body. This drive line comes out, and it's connected to a device that's a kind of like a remote. It's a monitoring device, but also you can change settings with it as well. And there's, patients are able to live relatively nice lives on this. Maybe they can't play sports, but they can. We have a lot of, we have children on these devices, older children who are able to attend school. And really, it's amazing. They can be at home, and the risks are relatively low with these devices. There are some risks of clot formation and things, but we manage those well. So this is a case report from Stanford that shows that this is a patient who was actually had a device implanted in 2011, and then this was released in 2018. So at this point, they had 7 years of that device working very, very well for them, and their decision was to do destination therapy. Patient was doing very, very well on it. So this was a very good option. This is another study. This one is out of Texas. It was reported last year. This is also a patient who was not a transplant candidate for some reason. And so, actually, I think I know. It was because they had multiple organs that were affected. And so they would not be a heart transplant candidate, but they were able to be stabilized with this ventricular assist device. And I don't know kind of what happened after this, but it seemed like this device really worked well for this patient in the initial period. And then here is another one. This is out of Lithuania, where they were able to, in a patient with Becker muscular dystrophy, use a ventricular assist device to bridge them to heart transplantation. So they successfully got them there. So this is a poster that they presented at a conference about this patient. And then there's also some studies. This one's out of Japan about female carriers. This is a very kind of advanced case unexpectedly who developed significant heart dysfunction and was able to be managed with a left ventricular assist device. And then this is just something I found in the news. I was very curious, but I couldn't find more information about how these two brothers are doing. But these are two brothers with Becker muscular dystrophy who, at least as of 2013, both had ventricular assist devices. And here they are with their, this is all you can see of the device. All right, so heart transplantation. This was a great paper that I came across from, I think it was recently, a couple years ago, that talked about transplant in muscular dystrophy. So there's a lot of hesitancy around it just because kind of life expectancy and other organ systems and how that's going to be involved. But there still have been quite a few cases that we can learn from, and probably some of them were just, maybe in some cases the muscular dystrophy was not known prior to transplant. And then in some cases, people just decided to move forward and had good outcomes. So these are 81 patients that they found in the UNOS database, which is the United Network for Organ Sharing, where it's a database where you can find all the kind of transplants that happen in the country. And there were 81 from different patients with muscular dystrophy. And here you can see that a majority of them had Becker muscular dystrophy, and probably because, these are the patients that tend to maybe be lower risk candidates and the team is more likely to proceed with this. And what they saw is that they had similar long-term post-transplant outcomes compared to matched cardiomyopathy heart transplant recipients. So patients without muscular dystrophy, they had pretty similar outcomes to them at 5-year mark and 10-year mark. So really, this is excellent. So basically what their conclusion from this is that if you have favorable skeletal muscle and respiratory function prognosis, then you can certainly consider heart transplant for these patients. Here are some other kind of newer things that I thought were interesting. So this is a very recent publication, actually just from last month, which is what we call genotype-phenotype correlation, where you're trying to see if the specific gene mutation that a patient has may predict what the outcome is going to be, and trying to learn a little bit more about how we can interpret the specific genetic data in order to provide counseling for patients when they're diagnosed. So in this study, they did find that there were some very specific deletions that were associated with some differences in kind of the timing of ambulation loss and also the odds of developing LV dysfunction. So I think that there's a lot more work to be done in this area, but this was a very interesting one. And then a little just briefly about investigational agents and gene therapy. So there is this follistatin gene therapy that inhibits a naturally occurring protein called myostatin. And so myostatin limits muscle growth. So if you inhibit it, then you will kind of promote muscle growth. So it promotes muscle growth and improves ambulation. There's some initial studies, I have this here, that this is from 2015 that was promising, but I think from what I could find, it seems like there's some follow-up trials underway. I'm not sure how much this is actually being used as of now. And then another one is the sevasemten. The Canyon trial is an ongoing trial. It targets skeletal muscle myosin to reduce the strength of muscle contractions. And so when the muscle is contracting very strongly, this is something that is causing kind of muscle damage over time. So if you reduce that strength, you can protect the muscle for longer from damage. And so this, just going to the website for Edgewise, it looks like this is well underway for the Becker population. They're in phase 3 here. So excited about this, for future results here. And then, as you know, for the Duchenne muscular population, there's a lot of talk about gene therapy recently, and FDA recently expanded the use of gene therapy that delivers these functionally shortened dystrophin protein, microdystrophin, via adeno-associated virus. And there's been some side effects that are, we have to monitor for. So this may be something that can lead to more options for Becker, but right now it's kind of primarily for Duchenne muscular dystrophy. But I think that there's a lot that's ongoing and a lot more that we could do in the future to really improve cardiac care for these patients. I think that's all I have right now. Thank you so much for your time.